We're going to talk about charge association, which is now the charge syndrome. And we'll talk about how I discovered the syndrome, the process, and then we'll discuss the various aspects of charge in the process. And how I discovered charge syndrome is going to be different than how you discover syndromes now. Because had I had access to what you have access to right now, it would have taken me 16 and a half years less to discover the syndrome. So, but I learned a lot in those 16 years. Okay. This is just a little bit to tell you how I got interested in this morphology. In the early medical school years, I did externships in the summer at the Children's Hospital in Louisville to make money, but also to get experience. And I found myself sort of more interested in the rare entities, and many of the rare entities were dysmorphic patients, although there were others that were rare that I also was fascinated with. And then when I started my pediatric internship, that particular interest continued. And I remember the first day on the ward when I started as a pediatric intern. The first patient I saw was a Rubenstein tabby. And at that time, very few people knew much about it. This one doctor, who was an infectious disease doctor, he's the one who identified it. And I thought, that's pretty cool. He just stood there and made a diagnosis of the Swear syndrome that nobody else knew anything about. I thought, I'd like to be able to do that. So I started looking at patients more critically that were dysmorphic and began to take photographs of the patients, obviously getting the parents' permission. And at that particular point in time, syndromes were not something very big in medicine. The term unusual looking child or funny looking child was the term that was used, and they would spend about a minute at the bedside and off they go to see their infectious patients or whatever else was on the ward at the time. So the parents weren't getting much feedback from the doctors about what was going on with their child. And so I promised them as I took pictures of the child that I would find out as much as I could about that particular disorder. So whatever I could find, I would come back and relate it to the parents. And the parents were very appreciative. It's also an ego builder for me because I started to get feedback from working hard, spending time in the library, so I did more and more of that type of thing. And by the time I finished my first year internship, I knew more about these disorders than the faculty did. So the last 2 years of my residency in pediatrics, they would often come to me and ask what was going on and to come see their patients. So that was another ego trip that kept me motivated. And so that's how I got started. And it was a camera that wasn't a good camera in the sense that it couldn't focus up close. So rashes and things like that didn't show up. But, 8 fingers on a hand did. And so I ended up taking more pictures just because I had a bad camera. And then in '68, when I was in the military, I saw my first patient with chondrodysplasia. I noted that that particular patient had other anomalies. No one knew what the patient had. I certainly didn't know what he had as far as an overall explanation for the multiple anomalies. But I put it on my memory back burner, and it sat there sort of irritating me because as it happens, charge anomalies are pretty specific, even though individually they're not common. And if you have enough of those type of features, you should be able to devise a pattern and make a diagnosis. But people hadn't been doing it at that point for a lot of conditions, but this was one of them that they did very little. There may be a reason for that. There's a lot of surgical problems with these patients. And so the surgeons tended to dominate the care of the patient, the attention of the parents. And of course, they didn't care what the patient had. They just wanted to repair whatever was going on with the patient that had a surgical potential intervention. And this is the first child I saw. He or she, I can't remember, I think it was a she, had choanal and had colobonus, had some small ears, not particularly malformed, and had some hypotonia. And since it's a girl, there was not a small penis to draw attention to that aspect of her features. So again, I just put that particular patient on the back burner and went on with other things, but never forgot how irritated I was with myself that I couldn't find a diagnosis for these unique set of features. I left Children's Hospital after I finished my residency and went into the U.S. Air Force in California, and my commanding officer allowed me to attend the genetics clinic at University of California in San Francisco every Wednesday. So those experiences continued to increase my interest, built my ego further, and the people at UCSF began to appreciate the knowledge I had, because even then, and even though they were experts in their own ways, they didn't know much about multiple anomalies. I had not done my fellowship with David Smith in Seattle. I was to do that after the mid-1970s. So I did do that with David Smith, and I began to notice that there was value in taking the rarer features of a particular group of features in a specific patient and searching out potential syndromes using that feature as a marker feature to go to the library. At that point, we had to go through the Index Medicus, and so I would look up Index Medicus, these huge monoliths of information that was boring beyond belief. But I got plenty of references from them, and were able to chase down other things. So that started my one of my approaches, and probably my most common approach to making the diagnosis of new syndromes, or at least to suspect that a particular syndrome is the rarest feature, because the rarest feature usually is much more specific, has lower association with anomalies, but high association with patterns. This is David W. Smith. He was my mentor, and he always only had one fellow. And he didn't do laboratory work, so he and his fellow, in this case me and Dr. Smith, saw all the patients together, and I did the initial evaluations, and then would present to him, and then we would discuss it, see what we needed to do, and determine what tests, if any, needed to be done, and what type of follow-up. And he would teach me at the bedside and make me think about things. And so there weren't but maybe 3 or 4 people in the United States, and almost none in the rest of the world, that were doing dysmorphology that were teaching, and certainly not one-on-one. So it was an ideal person. He was an ideal person to work with. He was very bright, very easy, big guy, about 6'4", red hair, as you can imagine. Although this particular screen, red hair is everybody. His hair is actually red. So the 2 years I spent with him were as about as positive experiences as you could have, and educationally speaking as well. So when I came to UCSF, I began to see some more patients with corneal atresia, and there I saw almost 1,000 patients a year. And so you see that many patients, you're going to see more patients with the features of corneal atresia and its associated anomalies. It was still clear that these patients I was seeing were not apparently all the same. They didn't all have the features in common, and I couldn't really deal with that diagnostically. And again, because I was so busy, I sort of put that on the back burner. But I knew that I had to sometime in the near future, study this in a more formal way and just take the time to do it. And between 1977 and 78, I reviewed all the University of California medical records, and these were not just genetic records, these were all the records. And using the marker feature of corneal atresia, that was the ascertaining feature. And I found 11 similar cases with corneal atresia and other anomalies. And they had features in common, but not one patient had all the features. So I was still uncomfortable. This is the original trial that I saw, and you can see the typical ear of a charged patient with the lower portion hypoplastic. It's deformed. The upper portion is often downturned, the superior helix, small mandible. This patient also had colobomas. This patient had all the features. And so I took all the patients I'd seen on the genetic services and all the patients I'd gleaned from the literature, and that added up to 17. And here you see the features and their frequency. Obviously, corneal atresia is 100% frequency because that's the feature I chose to ascertain the patients. But it turned out amazingly close. I had to eliminate very few patients from this group who were so far removed because of additional features that this is just the ones I actually ascertained with one or two exceptions. And if you look through this, you'll see most of the features that we've seen reported in charge association or syndrome, although the frequencies vary. They vary for different reasons. One, my ascertainment bias makes them vary. The mental retardation was 100% feature, and that's not true. If you think about these children who have deafness and blindness or severe visual problems, they don't test out well in infancy and as toddlers. And they were often, if not always, considered to be mentally retarded in those first 2 to 3 years of life. And a lot of these kids that I had got charts on were, 2 months, 3 months, 4 months. And they are generally hypotonic, have more truncal weakness, and so they have a lot of reasons why people would interpret their physical features as being mentally retarded. See, if you look at the hypogonadism, it's almost 100% in males, and frequently it was a borderline call, not frequently, uncommonly it was a borderline call as to whether the penis was small or not. You can see deafness was up there with a frequency of 40%. It's higher now because a lot of these kids, we weren't testing a lot of these kids just after birth, and they were very sick, and it was hard to test them and get accurate results. So that would be a minimum figure among these patients. Note there was cleft palate, which is another lower frequency feature. There wasn't a particular facial manifestation that you could gestalt, but there were things that were recognized in the charts that people made note of. One of the things I want to point out is the facial palsy, which is now considered a major feature of charge association, was noted in 4 of 17 at 23%. So that went from that percentage until the present time when it's 80 to 90% frequency. And short neck is seen sometimes because occasionally they'll have cervical vertebral anomalies. And then look at the tracheoesophageal fistula, esophageal atresia, small percentage that's remained in that ballpark since. You can also occasionally get duodenal atresia, which was not present in any of these original patients. And here's a collage of 4 of the 17 published patients. A lot of syndromes like Downs, like Rubinstein-Taby, like Williams, have a facial gestalt that you can immediately suspect the diagnosis. That's not true for charge, and I was very uncomfortable with the inconsistency of the facial features. And of course, there's some distortion because of the corneal atresia. Many of these patients had prolonged intubation, a lot of reasons to distort the face. The facial palsy can be mild. It doesn't have to be severe, but it is a permanent feature. So that gave us trouble. The consistency of the colobomas was even variable from most are retinal, but some are iris, and bilaterality of the colobomas was common, but you had to look in to see them. And it's not easy in a newborn baby to get into the eyes, look at the retina, and see the colobomas. Even the ophthalmologists have trouble with that. And so you had to really work at it to see, because you might see a patient, I didn't see it in those 17 patients because they all had corneal atresia, but I wanted to make sure they did or didn't have colobomas. You know, it's been literally hours looking in at the retinas, trying to see enough to say, yes, he does, or she doesn't have colobomas of the iris.
Do the corneal atresia have to be bilateral?
No, not at all. And also corneal stenosis is just a less severe form of corneal atresia. So you can have no evidence of corneal atresia and still have a corneal stenosis. And that usually shows up a little bit later as the child starts to produce more secretions and is only breathing out one nose, but the opposite nose often will have a collection of secretions that are almost like a little block of mucus that comes out periodically. So once I decided that this was an association worth risking whatever reputation I had, I presented 17 cases. Now, I want you to know that this was one author, one researcher, that's me, presenting 17 cases. If you see anybody in the last 10 years who presented 17 cases of anything where there's less than 4 authors, I'll give you $1. So,
less than 20 even.
less than 20. I was being very, very, sometimes they occupy the entire 3/4 of the page before you get to the abstract.
True.
But I presented this at the American Society of Human Genetics meeting in 1978 in October. As it turns out, the next year, Hintner, who's an ophthalmologist, published 10 cases of what looked like the charge association in the Journal of Pediatric Ophthalmology and Strabismus. Being an ophthalmologist, her ascertainment was colobomas. None of her patients had corneal atresia. If they did, she didn't report it. And she might not have known, because some of them were older individuals, late teenage years, even adults, who had already had their repairs, and if they survived, would not necessarily be recognized to have had corneal atresia. And then I published some 5 months later, these 17 cases in the Journal of Pediatrics. And then Bonnie Pagan and her group in Seattle put 21 cases together and came up with the Mnemonic charge association. And at that particular point, the syndrome was fixed in the lexicon of diagnoses, and people started reporting case after case. By 1978, or by the time I made the slide, which was probably about 1998, over 1,000 cases have been reported, and since then you can imagine how many more. So it went from maybe piddling around for some 16 years in one case, and then 4 cases, and then 10 cases more, until it came to pass. I sound like I'm giving a lecture, not a lecture, preaching. Came to pass that this became a recognized condition. Changed from, once the gene was found, it changed from association to syndrome. I still can't intellectually know why people like to use the term, like to get rid of the term association and say it can't be an association, it's a syndrome. I use association to mean that there's a group of features that are related to another feature that may or may not be a syndrome with a single etiology. And then if you find the etiology, as they did with the chromosomes, in those patients that have the group of features, then it's a syndrome because it's due to the abnormality on the 8th chromosome. But association is how I got started thinking about this as a recurring pattern that you could recognize. Sometime after that, on a previous talk, obviously many years ago, I put together what was reported up to that time, and you can see the frequencies changed. You note that atresia of the colani is only 56%, and about the most frequent percentage you get today, after you've added all the cases up, is somewhere between 35 and 40% frequency. And heart disease went way up. Colobomas went way up from where they were. The growth and retarded development stayed about the same. Since then, the retarded development has gone down for reasons that we've already brought up. The growth issues are important because they're only postnatal. These children are normal at birth, head circumference, and length and weight. So all those, you know the frequency of IUGR in multiple anomaly patients, and in particular chromosomal ones, but that's not true for here. The growth is retarded only after birth, not before birth. The ears stayed about the same. You can see the facial palsy is starting to go up. It was 25% in the original chart I showed you. There it's 54%, and now it's in the 80 to 90% range. It was always known they had swallowing difficulties, but any patient with corneal atresia has swallowing difficulties. But even after they were repaired, they had poor esophageal function and swallowing difficulties that sometimes took years and long-term placement of gastric GI tubes for feeding purposes. We began to recognize when more cases came in, the clefts of the palate were common, around a quarter of the patients. And occasionally you'd see patients who had cleft lip as well. So this is one of those cross-clefting syndromes where you get both cleft lip, cleft palate, or both, even though the majority are only going to have cleft palate. It also changes the facial gestalt. So most of the facial gestalt is altered through problems with different areas of the face that are malformed or not functioning normally, not that they're intrinsically formed abnormal. Here's a child who has the stents in for corneal atresia, bilateral. Was very poor prognosis, but you can see she looks much more normal as she's gotten older and has been relatively healthy. And you'll see as we show more of the cases that the face, while similar in some, is dissimilar in most and is not reliable per se. This is what the original charge stood for. I worked for literally months trying to get a mnemonic for the group of features I had, and Bonnie Pagan and her group, which also included John Graham, came up with this, and And this just took off. It was easy to remember. You could use it. People would recognize it primarily for the value of charge cards. Everybody could relate to that.
So how do we get more and more recognized as it because of heart defects? Because you said the ear anomalies aren't as common or as
Well, half the ear anomalies that's the frequency that's described as having ear anomalies. But as time goes on, people are more critical of the ear architecture. And most of the ears are not going to be normal in these people. And also, because of the internal ear problems, which are often lumped among ear, is the cochlear abnormality that is almost 100% frequency in this condition. The cochlear, or semicircular canal agenesis, which affects the cochlear apparatus. So most of the ears are going to be abnormal. They just weren't recognized as such. People would say, well, this ear looks normal to me, but it'd be small. So that's an abnormality. And so those originally got tossed into the normal range. But that's not fair. You can't do that. And here, most of these are going to be ears that are clearly abnormally formed. And you can see the boy in the middle top has the lower portion or the lobe missing. That's pretty typical. And some of the other ear abnormalities that you see in these other children, other than that boy, are found in lots of conditions, but there are very few conditions where the lower portion of the ear is missing. And there's a few very rare syndromes that have it. Infants of diabetic mothers who are malformed can have that ear configuration, but it's a good marker when you see that to think about Charge syndrome. I remember, well, we'll go ahead in just a few minutes. Let's see. I've got a distinctive face. I go back and forth on that. I don't think it's a distinctive face. I think there's secondary features that can make it look distinctive, and sometimes that's more than enough. Here you see more severe facial effect on the girl top left with a very inverted V-shaped mouth. Notice the ear is very typical with the lower portion missing. That's true for the patient to the right of her who's not related. Again, the lower portion is missing. They can have a prominent forehead, as you see in these two children. And as they get older, even though they start out often with a relatively small mandible, it gradually grows and becomes more prominent. And you won't pick up in let's say a teenager with this condition that the mandible was at one time small. We mentioned the semicircular canal hypoplasia or aplasia. They can have central nervous system anomalies, maybe in the range of 10%, and they're often midline problems. Agenesis of the corpus callosum has been reported in this condition. Limb defects and anomalies are low frequency, but they do occur. And the reason it's important to know that is that originally when we had patients with Charge syndrome reported, or at least presented, and people would make the diagnosis because their patient had a missing thumb. And because it's low frequency feature, people weren't generally aware that these patients can have preaxial defects. And there's been one with polydactyly as well, again proven by chromosomal studies or molecular studies. And renal anomalies, if you don't look for them, they're not the type that would show up in and of themselves, particularly in childhood. We talked about vertebral defects. One thing we did talk about is they can have some thymic problems and hypocalcemia, low frequency. That's why they were often confused with VCF syndrome, because there's some overlap in that syndrome and in this particular syndrome. Rarely, a couple times, omphalos has been reported. Hypospadias, rare. Hernias, not uncommon. Webbed neck is because the neck is a little bit short and it's not as webbed it's not a true web, it's the web you see with short necks. And Etiology occasionally, which gets it in the differential Vater association sometimes, particularly if the Etiology is not present or the retinocolobomas are not present. And there are patients who have neither of those. So you have to look at the other features to make the diagnosis in those particular patients clinically. Obviously, you can do your gene testing. Almost all the males have. Here's a child with hypospadias who also has micropenis and small testicles. Those are features that in the males are very useful as a feature, but most of the criteria for diagnosis don't include that. And if you exclude a 100% feature in the males, you're excluding yourself as far as making and thinking about the diagnosis. They do fail to thrive, particularly in the first 3 years or so. Some never grow back to normal. Others reach normal stature, weight, etc., head circumference. The postnatal short stature is proportionate. There's no osseous defects in these individuals. They don't have a bone dysplasia or dysarthrosis. And we talk over and over about what's called deaf-blind individuals and how hard it is for them to test out normal and to function normally, except with lots of intervention. They have poor coordination. Seizures are a feature, but they rarely are a feature that is an ongoing, prolonged problem. They're usually treatable and or go away. Sometimes they have delayed or inadequate puberty, particularly those males that have hypoplastic gonads. Another set of pictures, some you've seen. Again, you see the ear on the child in the middle, very typical. Sometimes these ears are cartilage deficient, and that's the reason they unfold and laterally protrude. And that's also the reason why the spear helix folds down. It doesn't have anything to support it. The boy on your right, you've seen before, but he has that ear too. You can see he's got had a GI tube as a trach. Trach sometimes takes years for it to be for the child to be able to grow out of needing it. We knew from the literature, after people began to recognize the Chart syndrome, that there were an occasional familial report. Usually, not always, but usually a parent and a child, occasionally two siblings, occasionally an unaffected parent that had an affected child that had a cousin, first cousin with the disorder. So as we were trying to decide what the etiology was, we had to deal with these families that were very difficult with the testing that we had available to us at the time as to how this was genetic, but certainly suggested that this was a genetic condition, these families, and until 2004 there was no etiology established, but that's when the gene was discovered. This is a family I saw that drove me nuts. Now I think I know why. The child on your right is 6 months old, female, had all the features of charge, but was mildly affected. Hypotonia was minimal, was growing pretty well. Would have been a definite charge, but you would always think, well, maybe I missed this one, this is something else. Her two half-brothers on the mother's side were severely affected with most of the features of charge, and they both died in early infancy. We did all the tests that were available to us at that point, and nothing showed up. And I eventually lost track of this family after I moved from California to Kentucky. And so I don't know what's happened with this family. But this could have been dominant with the mother being a carrier, not expressing the gene. Could have been a chromosomal disorder where the mother's a carrier, but distributed deletion or duplications to the boys, but not to the girl, or vice versa. So I didn't really know here. This is a girl who is, again, had all features charged, but was relatively mild and had the two severely lethal affected half brothers. Now, I put this in here to remind me what CHD7 stands for. I never figured out what the 7 is for, so I put a question mark there. But that's, at the time this chart was made up, that was found in, excuse me, 66% of patients. But as you know, there's a fair number of patients who, by the previous testing, still had charge but didn't show any abnormalities. So with molecular testing, that's become in the range of 80 to 90% now can be diagnosed by testing either the gene or using molecular testing. And it turned out that this is not a dominant gene with extremely variable phenotype. I've seen reports, there's 32, maybe a little bit more than 32 cases reported in literature that have a familial occurrence, and that's where you can pick up variability the most because you compare sibling with sibling. And there are some people in those families that don't even look abnormal, that are carriers or have one or two of the milder features of the CHARGE syndrome. So they can be very difficult to suspect, even though you've got a familial occurrence, and they are, in some of those families, obligate carriers or affected, some of the other or both.
Majority is developable. Majority is developable.
Yes, exactly. And I think since you only have 32 cases that are familial, and the other 2,000 plus cases are de novo, you can say that with surety. And here's same patient, both pictures, typical here. This is the one that you saw earlier that had the severely triangulated or inverted V mouth. And she's still very hypotonic, and I doubt that she'll ever be even low normal. She had too many neurological problems and was still functioning poorly. I think she's like 4 years old in that particular picture on the right. So, fortunately or unfortunately, I've been defined by the CHARGE syndrome. I spend less than 1%, I did spend less than 1% of my time with CHARGE-related issues. So the other 99%, you don't get your just desserts, if you will. The families, of course, I've been involved with the CHARGE Association, now CHARGE Syndrome Association, and been to many of their meetings, and their children have taught me a lot about the condition and ask pertinent questions and allow you to study their children regardless of what it takes to get the sample you need. So that's been a wonderful experience for me. I've been involved with the CHARGE Syndrome Association. I've been involved with the Prader-Willi Association. I've been involved with Williams Syndrome Association. Those are the three that I spent most of my time with as far as parent groups. And this is a Kentucky patient. And remember I said that the jaw sometimes can be extended and not small by the time when they get into adolescence. This boy had good speech, had mild hearing problems. You see he has web neck there, and he has a Kentucky driver's license. Now, I don't know if the driver's licenses are given out as freely in South Carolina as they are in Kentucky, but a lot of people drive in Kentucky that shouldn't. A lot of people who are normal mentality shouldn't be driving either. And here's one of the parent meetings with a patient and his mom. Okay, so find your syndrome, report it, be famous. Or infamous, one of the two.